Good morning, everyone, and welcome to the Institute of Global Health Sciences Grand Rounds. We're pleased today to co-host this Grand Rounds with UCSF's Center for Health Equity in Surgery and Anesthesia. My name is Chelsie Anderson. I'm a fourth-year medical student at UCSF applying into general surgery, and am completing my master's in global health at the Institute of Global Health Sciences. My passions lie in global health equity, education, mentorship, and supporting the pipeline for underrepresented minorities into medicine. I'm so pleased to introduce our host and chair today, Dr. Haile Debas. Dr. Debas is recognized internationally for his contributions to academic medicine and is widely consulted on issues associated with global health. At UCSF, he served as the Dean of the School of Medicine from 1993 to 2003, and the founding executive director of Global Health Sciences from 2003 to 2010. He also served as vice chancellor for medical affairs for 6 years and chancellor for 1 year. A gastrointestinal surgeon by training, Dr. Debas chaired the UCSF Department of Surgery from 1987 to 2003 and is the Maurice Galante Professor of Surgery Emeritus. He also was the founding director of the University of California Global Health Institute from 2009 to 2016. Dr. Debas has held leadership positions with numerous membership organizations and professional associations, including serving as president of the American Surgical Association and chair of the Council of Deans of the Association of American Medical Colleges, AAMC. He served for 2 terms as a member of the Committee of Science, Engineering, and Public Policy of the National Academy of Sciences, served 4 years on the advisory committee to the director of National Institutes of Health, and was a member of the United Nations Commission on HIV/AIDS and Governance in Africa. Dr. Debas is a member of the National Academy of Medicine and a fellow of the American Academy of Arts and Sciences. He currently serves as chair pro tem of the Board of Trustees of the Aga Khan University, and previously served on the Board of Regents of the Uniformed Services University of the Health Sciences. He was instrumental in the creation of the Consortium of Universities for Global Health, where he served as the founding chair of the Board of Directors from 2009 to 2012. Dr. Debas was a lead editor of the Essential Surgery volume of Disease Control Priorities, 3rd edition, or the DCP3, published by the World Bank in 2015. It's a true honor to have you with us here this morning, Dr. Debas.
Thank you, Chelsie, for that generous introduction. I would like to welcome all of you to this IGHS Grand Rounds, and on behalf of the Center for Health Equity in Surgery and Anesthesia, CHESA, I would like to thank Professor Sepulveda and IGHS for inviting us to deliver this Grand Rounds. This is the first Grand Rounds that CHESA is giving and represents the beginning of a series of Grand Rounds on perioperative health equity that it plans to hold regularly. I am pleased to co-moderate this Grand Rounds with Ms. Chelsie Anderson, a UCSF Masters of Global Health candidate and 4th-year medical student applying for general surgery residency. Chelsie is a passionate advocate for global health equity, education, membership, and pipeline support for underrepresented minority students in science, technology, engineering, and mathematics. It is no wonder, therefore, that Chelsie was inspired to choose as her capstone project pipeline support for underrepresented minority students in medicine. UCSF has done much to bring global surgery to national attention, thanks to Dean Jamieson, Professor of Economics and member of the IGHS faculty, who was the first to see the importance of surgery in global public health. He asked me to write on surgery in both editions 2 and 3 of Disease Control Priorities, a publication of the World Bank, the publication of DCP3 and of the Lancet Commission on Global Surgery in 2016 gave a major impetus to the popularity of global surgery. As one of the pioneers in global surgery, it's fitting for UCSF to create CHESA to bring together the global surgery interests of all surgery departments to create a collaborative center. I want to acknowledge the essential leadership and support of Dr. Julianne Sosa and the other surgical chairs at UCSF. But without the total dedication and untiring efforts of Doruk Ozgediz from surgery and Michael Lipnick from anesthesia, CHESA would not be here today. So what is global surgery? The best definition is that given by Beas, which states that global surgery is an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical and anesthesia care, with special emphasis on underserved populations and populations in crisis. It uses collaborative, cross-sectoral, and transnational approaches and is a synthesis of population-based strategies with individual surgical and anesthesia care. Now, I would like to briefly answer two questions. How severe is health inequity in global surgery? And second, what is the importance of surgery in population health and universal health coverage? First, the inequities in global surgery. The inequities in global surgery are staggering. Out of roughly 250 million operations performed each year worldwide, only 6% are performed in the poor third of the world's population, which carries nearly 30% of the global surgical disease. There are 10 times more surgeons per 100,000 population in high-income countries than in low and middle-income countries. The mortality rate for cesarean section in Sweden is 0.04. The corresponding figures for Asia and Sub-Saharan Africa are 40 to 80 times and 20 to 1,000 times greater, respectively. The second question is, what is the importance of global surgery in global health? The global burden of diseases, including trauma, is estimated at about 30% of the total burden of disease. There is now growing realization that without the provision of affordable, accessible, quality, essential surgical care, universal health coverage cannot be achieved. Both DCP3 and the Lancet Commission on Global Surgery have concluded that universal coverage of essential surgical services should be publicly financed early on the path to universal health coverage, given that it's affordable and highly cost-effective. Implementing these recommendations, however, is not going to be easy and will require nations to prioritize funding for global surgery. A key requirement for success is surgical leadership, and that's why centers like CHESA are important. They leverage the enthusiasm, optimism, and energy of students, residents, and faculty to provide global surgery solutions. They will help generate rigorous research data that will form the basis for building the case for global surgery. They will develop the training and competency standards that will be necessary to develop context-specific essential surgical services in low-resource settings, whether globally or here at home. Success will be critically dependent on multidisciplinary approach, not only within the surgical profession, but more broadly with other health and non-health disciplines. I am confident that multi and interdisciplinarity will be the hallmark of the approach that CHESA will adopt. Well, that ends my long-winded preamble. Now to the main menu. And for this, I like to pass to Chelsie. Chelsie?
Thank you, Dr. Debas, and it's my pleasure to moderate this panel with you this morning. Before I introduce our speakers, I'd like to encourage our participants to submit questions through the Q&A box. We will moderate a Q&A at the end of the session and look forward to your questions. You can find the Q&A button in your Zoom controls. And so without much further ado, I'm so pleased to introduce our speakers. Dr. Phyllis Kisa completed both medical school and her Master of Medicine at Makerere University in Kampala, Uganda, followed by a fellowship in general surgery at the College of Surgeons of East, Central, and Southern Africa, CHESA. She completed her pediatric surgical fellowship training with CHESA, a hybrid training with part in Uganda and part at BC Children's Hospital in Vancouver, Canada, in both pediatric general surgery and pediatric urology. She also completed a formal clinical fellowship in pediatric urology at BC Children's. Dr. Kisa is a lecturer in pediatric surgery at Makerere University and conducts research in perioperative nutrition and improving pediatric surgical care. Dr. Doruk Ozgediz is Associate Professor of Surgery at UCSF, Director of the UCSF Center for Health Equity in Surgery and Anesthesia, CHESA, and on the leadership team of the Institute of Global Health Sciences. He trained in both medicine and completed a general surgery residency at UCSF before pursuing a pediatric surgery fellowship at the Hospital for Sick Children at the University of Toronto. Dr. Ozgediz also completed a Master of Science in Public Health in Developing Countries at the London School of Hygiene and Tropical Medicine. He became involved in surgical collaborations in Uganda in 2003, and since then has been part of multiple collaborations to strengthen surgery and anesthesia care there and in the region, mostly through support of capacity building initiatives. Dr. Ozgediz generously shared his knowledge, connections, and passion for equity with me as we built a pilot summer global surgery program for underrepresented minority high school students that ran successfully earlier this month. And we hope to have 20 new surgeons join us in the field in about a decade. Dr. Ozgediz, Dr. Kisa, welcome.
Thank you. Sorry for that bit of delay. Thank you for inviting me to take part in your very first grand round of your Global Institute. I'm really privileged to be part of this, and in a strange way, thankful to COVID, because it might not have been possible for me to be here remotely taking part in your grand round, but this offers a great opportunity. Today I'll be presenting to you on really the story of pediatric surgery in Uganda and the journey that we've taken over time. And it's really the best way for me to describe how partnerships in global surgery could go and how ours has been the way it's been, and some of the challenges and opportunities that we've had. I call it "We Cannot Walk Alone." Certainly, I've copied it from Martin Luther King's talk, but in life, and surgeons know this best, that it's always team. If you try to go alone, there's nowhere you're headed. You can't go far. And so you need support from so many people. And that's why I call this talk, We Cannot Walk Alone. And in the same way, global surgery is in the same way, that you always need people to give you that step up, but also yourself, you'll give others a step up. And without everyone taking part in this link, no one can get where they need to get to. Oh. I just want to start by saying that in a country such as Uganda, we really have few pediatric surgeons. Since this was published a few years ago, we have 7 surgeons in the country. 5 of us are in one center and 2 others are in different centers. And for our population of 44 million, with over 50% being under the age of 14, this is a lot of babies and children to look after for just a small group of surgeons. It makes our work really difficult, but also we've had to be a bit creative in how we deal with surgical needs of children. But in offering this type of care, we've not done this or taken this journey alone. We've had help. On an average day before this pandemic, this is what our clinic would look like on a day, and this is just a tip of the iceberg. These mothers and fathers are endless. Like every time you see 20, this whole place looks like it's not been touched at all. And with such challenges, it's never easy to give the patients the best type of care that you can. And this is just another bit of the previous slide saying that there's lots of work to be done. And with such a small number of surgeons, it makes work really difficult, and sometimes the quality goes down. What has happened that to be able to offer the best that we can is over time, I will call it friendships. We've made friends and we've been supported by friends over time, because some of the things we've been able to achieve have been possible because of these friendships. If I just say collaborations, it does not go to the beats that our friends or the lengths that our friends would go to try and make things work for us in our environment and to help us reach the journey or to the road where we've reached right now in our journey in offering pediatric surgical care. And many times, because of such huge numbers, we've depended on surgeons in regional hospitals and other centers. And these surgeons include medical officers who are physicians but without specialization or residency. Then there is the general surgeons as well, who are also offering surgical care. Many times we'll have patients presenting with complications to surgeries that have been done, but also there is also the others who've either been misdiagnosed or treated temporarily with some things, and they do present to us very late. I mean, in your own center, when a child presents with Hirschsprungs, I mean, but before they go home, they've had their pull through and they go home, possibly without a stoma. I mean, this boy comes to you and he's a 9-year-old. Frequently, these children are stunted. And many times with some of their problems, they're not able to go to school. And also with things such as stomas, they have them for such a long time. Almost all their complications could occur. They stenose, they prolapse, they do everything. And because we are so overwhelmed by emergencies that many times it's really difficult to get to some of the urgent things, but also because we depend on other people to do some of these temporizing procedures for us, they're really varied. I mean, this child had Hirschsprung's disease, but a loop stoma was constructed, and this is him right here, and it really stenosed. And by the time, sometimes they don't have the right information, and by the time they come back to us, they're really doing poorly. I mean, it's such a belly, the child's barely breathing. Many times they're really sick. But like I said, this has been a journey that has started with so many people being interested. But I like at this moment to mention that recently we lost a colleague. He's called Sam Mutumba. He was one of the first general surgeons with that helped establish the pediatric surgical unit at my hospital, which was really the first pediatric surgical unit in the country. And he's been a mentor to many. And he passed last week from coronavirus. And I'd like to specially mention him that he's one of the first people to tell me that he'd like for me to join the pediatric surgical unit and train under them. And it's really sad that some of these people do pass on, but he's left a great legacy, and I'd like to honor him at this point. And with people such as those coming before us, they made friends. And when people talk about networking at meetings and visiting universities, it's a true opportunity of networking. All these people that you see here, not all of them some were met at meetings, and they find out what is it that you do, what is it that you need. And some are professors of surgery. They came with their fellows, and those have since become pediatric surgeons who've also come back to Uganda to help us with our work. At the time when some of these friendships were being made, we started with things like, how can we help you? And at that time, there's lots of patients. Like in the previous slide that I've shown you, it's overwhelming numbers of patients. So many patients have waited so long. And at that time, the real help was, how can we deal with these numbers? And people offered to come spend at least 2 weeks, sometimes months on end, with us to help us beat some of these numbers, and in fact go to some of the regions, because many children are not able to come to us in the capital or in the center where I work because of either language, financial problems that prohibits them from coming. And so we did what we call surgical camps, and many times we went to districts outside of our own center to offer this. And we went with a lot of our colleagues that we've made over time from different countries. Particularly, most of them have come from North America, but other hospitals in the country have had friends coming from Europe. And we've been able to do lots of surgeries. And over time, we've been able to do something about those numbers. But for every child we operate, I think there's another 10 being born at that moment with the same condition. So we never really beat that number. And we'll continue to need help, but still our needs have changed as we've gone. So from coming from something like that, with having more people on board, it was, what is the next step? The next step was, we need to develop local capacity. And that was including training of pediatric surgeons and pediatric anesthesia providers. And so some of these, it's not been an easy way, not been easy getting training. And almost all of us who've had a fellowship training in the country, at least maybe the first 5 surgeons in the country, the training opportunities were not there. It was someone you met at a meeting and they wondered what your hopes and dreams were, and there were no opportunities. You've tried to apply to all sorts of places and the opportunities did not materialize. And it's not easy to get a place to train. And over time, we've been able to start a fellowship training under CHESA, but also to get placements in the external sites, like at Yale, at BC Children's Hospital, where 3 of our pediatric surgeons have trained in pediatric surgery, and another surgeon is going to Edmonton to have a placement over there. But also now we have a robust training, and we almost have 1 to 2 fellows every year in training with us. And this has helped us build the numbers. Yes, 7 is a modest number, but it's way better than way back in 2012 when there was 1 fellowship trained pediatric surgeon in all of Uganda. He did not take vacation. He did not go to a conference. He was not able to do anything. He kept working. And all this work was just emergencies. He was not able to publish anything because, I mean, you're really buried in trying to offer patient care, and it's impossible to be able to do anything else to advance yourself academically because of that. So like I said, we've not been struggling by ourselves. And this is a picture just to say some of the places where we've been. In this picture here is one of the children that we operated, one of the first children that at our hospital survived after having a surgery for esophageal atresia. This was back in 2012, I believe. And this anesthetic machine that probably the oldest people in the audience probably have never seen. This is really an old machine, and it was the only machine at our hospital that could ventilate a child that was less than 3 kilograms. And so we did a surgery on this baby, and the machine had to move with the baby from the operating room to the intensive care unit. When we go to the intensive care unit, we were told that if we did not look after the child ourselves, there would be no staffing for the child. People are not comfortable looking after children, but they also didn't have enough people to do that. And so at that time, I was a resident in surgery, and myself and another anesthesia resident spent 3 days handbagging this child because this machine failed after 6 hours. And so we handbagged the child for 3 days. And I'm glad to say that this child is doing very well now. Fast forward to about 5 years later, we'd gotten better provisions, and an organization from Scotland called Archie Foundation did help us equip an intensive care or HDU area with a ventilator, monitors, the concentrators, and all sorts of things, tubes, but still we didn't have people to man this this space, so to speak. And from this last picture here, you will see pediatric HDU scheduling. So this child, same condition, now we have machines, but again, we still continue to face challenges. We did that surgery, and the surgeons and the anesthesiologists, we moved from the operating table to this space to offer the intensive care. And you can see the physicians named here, and the anesthetists and the surgeons that have been mentioned. And I had Mike Lipnick mentioned before, and he actually helped us set up this machine on the morning before the surgery happened. It was a crazy morning. We got the machine working, and basically we tested the machine on the baby, not on anyone else, or even before. Like, we did all the settings that very morning when we're doing the surgery. The child is doing well as well, but this is what it tells you, that we need all sorts of people to help us get to where we need to get to, but also as a surgeon and anesthesia providers, we don't always have all the help that we need, and working together, we're able to offer the intensive care for these children to get them out, and they're doing well. And in some of the ways I've spoken about the surgical camps going to the regions, with some of these activities, if we went to a regional hospital to offer these services, what it means is that at our own center, there would be no one there to look after children, whether emergencies or those requiring elective procedures. And I'd like to say that without collaboration such as that with UCSF or Yale or University of British Columbia, it's not possible to do this, because when they do come, they offer extra hands for teaching, for surgeries. And so you're able to split the teams to go offer services elsewhere, but also to continue offering services in our own environment. And with this, we have so many children that are unable to get to us for all sorts of reasons, and we're able to get to them. But also with these types of camps, we're able to empower surgeons in those regions or anesthesia providers that some of these surgeries, whether emergencies or the others, are not impossible to perform in their own environments. So we do them there. Even with assistance, yes, but we do them in their own environments with their machines, so that they become more comfortable doing some of these things when we go. And this is just a summary to tell you that these have not just been one surgeon showing up to do work. It's been different institutions, but you always go to the same places. It's been the same people. If someone comes with a fellow, probably the next time that fellow is a staff person, and they keep coming to the same to the different places, and they continue working with us, the same people. And I believe that having the same local coordinators of some of these activities contributes to longevity of some of these partnerships. When you have people changing all the time without the same core people remaining in any of the parties, something always dies somewhere, because people don't always have the same dreams, especially when you don't plan for the succession properly. And so as our work became easier, we started, writing about some of the work that we do, immortalizing ourselves in print, so to speak. So someone might remember that there's some things we do see over there, and we do get lots of challenges, and in different ways, we find ways to deal with the problems in our practice. But like I said, we do not do this alone. Some of these are some problems that it's the first time you're seeing them, and so you're quick to send messages to people that you work with to get more insight to it. They also ask other people. There's an expanded family of people that consult, even those that have never come to a country such as Uganda, that continue to support us in the work that we do. And some of these things in helping us with the daily management of patients, helping us getting the work published, just to see some of these fruits come about, is very helpful. But with all this work that we're doing, in about 2014, we realized that we're doing all this work, but so many groups are coming into the countries in pediatric orthopedics, in neurosurgery, in oncology, all the anesthesia, in all sorts of areas, general surgery, urology. But none of us, the left hand did not know what the right hand was doing. And so we organized a meeting in 2015 and brought everyone together. And we try to understand what our problems were, what were the successes, what are the challenges, and how have we tried to meet this. But we try to work together and to link everyone locally. And I'm glad to say that following this, we published some of our work in trying to follow up with the things that we had discussed that day, but also to follow up with some of the achievements we had made following such a meeting. And one of the things coming out of that is for us to perform a pediatric surgical foundation. It's still in infancy stages, but we believe that this will be able to coordinate all the work to do with children's surgeries in the country in the years to come. One of the things we're continuing to do is we continue to try to empower surgeons or surgical providers in non-specialized centers to perform surgeries for children, particularly emergencies. And in 2015, we designed this course, but ran it for the first time in 2017. A case for pediatric surgery. It was developed by local surgeons with assistance from some of our collaborators, and we've delivered 3 of these courses, and it's been helpful, and we've been able to get some feedback from the attendees of this course, and we hope to improve it as time comes. It was really contextual, and it's really been helpful for some of the tricks that we've learned along the way. We've also been able to run prospective database on our ward. And again, this has been one of those things that without help from abroad, it might have fizzled somewhere. But also we've had tons of publications come out of this. And with our colleagues from abroad, we've been able to get a lot of work out of this. And again, it brings some of the medical students that come to our centers from North America or from elsewhere. They also come, we're able to give some of the work to them, but they also help do some of the work for this. And at the end of the day, we're also in some of these publications or improve some things. And I'm glad to say that some of the data that has come from work such as this has helped bring about kids operating rooms. This is a Scottish NGO that is currently building so many pediatrics operating rooms across the world, in sub-Saharan Africa, in Asia, in Central America, in the rest of Latin America. And it's really helping a lot of pediatric surgeons, helping them have dedicated space and right equipment that they need. They service a lot of these machines, and this it's one of the huge things that people are not able to give. It's such a huge investment, and they've been able to do that. I mean, you can give all the help, and now you have all the skill, but sometimes when you don't have the right tools, it's impossible to do some of the work that you'd like to do. And Kids OR has been able to do that for us. And the work from Uganda helped this explode globally, so to speak. And we're proud to be the place where it all started. And this here is David Cunningham, who's the CEO, and Gareth Gates, who's the founder. And just to say, has all this been the end? No, I think it's just the beginning. And I think we've all said just to now, realize what the potential is. And recently, in October of last year, we separated a set of conjoined twins who had joined in the spinal cord, in the perineum, and the lower back structures in lower bowel and the urogenital tract. And we successfully did this with an all Ugandan team, but this might not have been possible without some of our collaborations. We used 2 theaters that had been specially equipped for us, and we consulted with all these colleagues, and over time, this collective training to be at the country at the same time in pediatric specialties, pediatric neurosurgery, plastic surgery, pediatric orthopedics, pediatric general surgery, pediatric urology, I don't think would have been here. Pediatric cardiovascular surgery wouldn't have been here without the help we've received or being partners with or collaborating with centers from abroad. We've been helped. And I'd like you to know that in the last 6 months, we've been able to separate another 2 sets of conjoined twins. It seems like they're falling onto our table so frequently. But again, this expertise might never have been here without the opportunities that the people we collaborate with have not helped bring to us. And it's not been easy. Many of these opportunities we've had to actively seek out. But again, you seek out, but you're seeking out from your friends. They know of someone who might give you the opportunity. To give an example, myself, when I did my pediatric urology training, I assisted a pediatric urologist one time, and he spoke to my boss that I'd like to train this doctor. Would she be willing? And you know, with such a conversation, if I'd never had the opportunity to train with this pediatric surgeon in Canada, this pediatric urologist might never have seen me or worked with me this one time, and immediately he offered me the opportunity. And these are some of the things that collaborations do. And but we still have faced a lot of challenges, and we have to actively seek this. So currently, for example, I'm trying to get some doctoral training because the university requires that from us. And it's not been easy, but again, I've been able to put this doctoral committee together, and it's been, I should say, easy because of all the people that I know from all these collaborations, lots of advice from people in different areas, but it's not easy. You have to be a go-getter. You have to be able to listen to people. But what I say is when you meet people, make it a true network. Let them be people that you never lose touch with, because you never know when you might need them or when they might need you, because I mean, the world is round, and I mean, we all keep going around. And like I said at the beginning of this talk, that surgeons know it best. Every cog in the wheel means the outcome of the patient, good or bad. And if everyone does what they should do, then we get to where we're supposed to do. So use everyone in your environment to get where you need to get to. Thank you. And I'd like to invite Dr. Ozgediz to give his talk.
Thank you so much, Dr. Kisa, for joining us. It's great to share this with you. And thanks very much to Dr. Debas and Chelsie for the earlier remarks. Can folks see my screen? Yeah. Great. So this is it's a great event for us. As Dr. Debas mentioned, we're kicking off our CHESA Grand Rounds series. We're really excited to do this with IGHS, and we're grateful for the IGHS community for inviting us. I'm just thrilled to be here today with everybody. Dr. Debas has been such an inspiration. We have a lot to do to carry forward his legacy. Chelsie, we look forward to everything you're going to do, and I think you represent so much of the passion for health equity that our trainees have here. And Dr. Kisa, so excited to continue working with you. I think the things that you brought up in your talk around relationships and family and networks, I think it gets to the heart of why we do a lot of the work that we do. This is just a brief outline of some of the things I'm going to talk about. Our center, which is relatively new at UCSF, some of the background in global surgery, expanding on what Dr. Debas talked about, some of my own prior work and ongoing work, and some future directions. And hopefully this will just be a jumping off point for ongoing conversation and future discussions. So in the last year, thinking about our center is called the Center for Health Equity in Surgery and Anesthesia, or CHESA. I think there's been a lot of thinking and more thinking about what global health is. And so I think it's really important for all of us to think about what it means to us. I think it really depends where you are in the world. And for a lot of folks, it means going somewhere else. Or it's a lot of folks, it means being right where you are. And so that was something that we thought about in deciding what to kind of call our center. And when we kind of thought about a lot of the community here, the feedback we had, and as we looked at what we were doing, we really conceived of health equity as really the central kind of theme, not so much the place of work, but really kind of getting behind health equity as a primary mission. And I think this also was enveloped in the COVID-19 pandemic and our challenges to address disparities, not just through the direct, but also the indirect impact of the pandemic. And also, I think our national reckoning with structural racism as a major public health issue. And this is just a survey of surgeons in the US looking at, do you think that disparities exist in healthcare? And a very minority did in our own country, and less than 5% thought that disparities exist in their practice. Kind of shows you how steep a hill we have to climb to address our issues here in the US around structural racism. I think this strand of thinking also in the global health space has been around the concepts of decolonizing global health. And we've had a lot of conversations within our campus, nationally, internationally around this. I've put a few links to some transformation dialogues that Lifebox and colleagues have hosted. Nicole Starr, one of our Starr surgical residents, wrote something about this recently. These are connected strands of conversation that all link towards health equity. And so as we look at the problem statements, or some of the things that we as a center, I think in many of similar centers are kind of thinking about is in the global space or the international space, partnerships have been sometimes driven excessively from our side, from the high income side. Within institutions, we've been relatively siloed between disciplines, and we haven't integrated local work in our communities with international work. And sometimes our research hasn't been responsive enough to what's really needed, and that our training programs have lacked diversity and inclusion. And these are some of the things that I think we hope here and also regionally, internationally to tackle. Our center mission is really pretty simple, is to advance equity kind of as the primary goal. It's not just surgery, anesthesia, and perioperative care, which have been highlighted in the previous talks, but essentially a team approach. It's not just about doing an operation, it's about safe anesthesia, perioperative care, and nursing. And that these are some of our guiding principles that we adhere to and are hoping to champion around health equity, local and global, and really implementation and impact evaluation. A little bit about our center structure. We have a great executive committee. I'm really excited to be working with the people I work with at UCSF and their local and international networks. You've heard about Mike Lipnick in anesthesia. We have an incredible group of anesthesia providers and activity in the Department of Anesthesia, both in Uganda and outside Uganda, and through the WFSA, and Adrian Gelb and others. Marissa Beck, who joined our faculty last year, who's a trauma surgeon, has been very active in Bolivia and works locally on violence prevention. David Bain in urology, who works a lot around social determinants of health and has a relationship with Guyana, and Colleen Sabatini, who also in orthopedics, who works in Uganda with the Korsu Rehab Hospital in Entebbe, and really has worked very closely with her partners there around conditions like osteomyelitis and gluteal fibrosis, and really has worked to increase access to musculoskeletal care. We also have a big community of orthopedic providers here through IGOT, the Institute for Global Orthopedics and Traumatology. So just a great network, and folks, I hope all of you can meet these folks, and they'll be featured in our grand rounds with their partners. So please join us. And Lauren, we're so excited she's here. She joined us from PATH in December and has brought us a tremendous amount of expertise and organization, not just for this event. And as I hope many of you who haven't had a chance to meet her can meet her. She also has a prior background in global orthopedics through Miracle Feet. We also have an extended leadership council with representatives from many of the surgical subspecialties: dermatology, ENT, neurosurgery, ophthalmology. We have a very active student group and obstetrics, all represented, and a big membership and really a global network. So I'm really excited to be working with all these colleagues. They all lead local or international programs. So it's just it's an exciting place to be. Our buckets of work are really around workforce development, training, education, research, partnerships, which is a highlight of today, and it couldn't have been expressed better than by Dr. Kisa, and advocacy and policy. Over the last year, some of the things we've been up to, for those of you that haven't really kept up with us, seed grants. We've awarded a number of seed grants that have supported both local equity initiatives and international projects. Many of us have been working with anesthesia and surgery networks to expand online education and mentorship, since we haven't been traveling, especially those that have been involved in clinical capacity strengthening initiatives. We've worked on a health equity curriculum that's been delivered to our trainees in anesthesia and surgery. And then we've been very involved with global networks in managing COVID. I have to highlight the anesthesia USAID project. If those of you that haven't had a chance to go to the Open Critical Care website and at all the resources. This has been an incredible project led by Mike Lipnick and many partners, both inside and outside UCSF, that have really highlighted the importance of the oxygen ecosystem and perioperative care in this particular kind of time of need. And we can share that link if you don't have it. So for me, some of the background and prior work, when I was a med student, dating myself 22 years ago, there was this feeling, surgery is not cost effective. Where does it belong in global health? And some folks even told me, just if you're serious about global health, then just go into infectious disease and get a public health degree. I did get a public health degree, but I went into surgery. But we've often been, the outside of the fun group, and we tried to get in. That's changing, but changing slowly. And then I think working internationally, I've just felt, having trained here and been mostly clinically based here, we have to be really humble because our outcomes here are lag far behind other high income countries. We also don't take care of our young people. We have a very high incidence of firearm deaths, just to pick one metric. So we have a lot of work to do at home and a lot of reasons to be humble when we're working outside our own environment here. Dr. Debas mentioned the surgical disease burden, the DCP3, which some of you may be familiar with, which highlighted since the 30% of the global burden of disease is treatable, and there's an increasing proportion of non-communicable diseases. We have a great global cancer program here that has a lot of programs around cancer being increasing greatly in incidence and severity. The surgical burden is greater than HIV, TB, and malaria combined. These are not to say one is any more important than the other, but just to say there's been less funding, certainly for surgical projects. And I think within the surgical community, we've all acknowledged that we can't just focus on the operation, that it's about the ecosystem. And we're all, I think, very mindful of everything outside the OR and how it affects the outcome, as Dr. Kisa explained in the very concrete clinical examples that she gave. Equity, what are some of our metrics in some of the key areas? Trauma, 90% of road traffic deaths are in low-income countries. 95% of childhood injury deaths are in low-income countries. Brain injury is a major sequelae. Musculoskeletal long-term disability is a major issue. Emergency obstetric care, which Dr. Debas highlighted, the percent of and share of maternal deaths in LMIC, which is another major focus at UCSF through global maternal health programs. Cancer, which I just mentioned, a disproportionate impact in low-income countries, and many of those patients, many of them will require surgical input. In our own backyard, we have major issues. In California, Black men in their 20s, 20 times, and Hispanic populations, 5 times the firearm fatality rate as whites. Maternal mortality here lags in Black women. In my own world of pediatric surgery, we have higher rates of ruptured appendicitis in Hispanic populations. And then our rural populations in California in general have worse access to care. And some of that has been documented in certain cancers. So we have a ton of work to do here. To me, these things all overlap, and it's basically the same types of access barriers that we have to keep in mind. We've tried to build in the concept of the social determinants of health more in our own health service delivery here, and thinking about what are the social needs that we need to address for our communities and our populations if we're going to do better. These are also things we're trying to teach more than we ever have before in surgery and perioperative care. The group that I helped start in 2000 to shift kind of the international space in 2008. I finished my general surgery here in 2007. I lived in Uganda for a year and had already been working on collaborations. But the GPAS group, the Global Partners in Anesthesia Surgery group, was really a group that we started to help support local, talented, young trainees who wanted to be surgeons and anesthesiologists. You see some of the collaborators that are pictured here. And it really was the acknowledgement that as academic institutions alone, we're kind of limited in what we can do. We have to partner with foundations, with charities, and it's very hard to fund capacity strengthening compared to maybe more traditional hypothesis-based research. So over the years, that group has supported many local Ugandan surgeons and anesthesiologists to complete their training and to stay on as faculty or to pursue extra other training. And this has not been just one group, it's been many groups that have contributed to this, but personally, I've just benefited so much from partnering and really humbled by the drive and the resiliency of a lot of the folks that you see here on the screen, and people like Dr. Kisa, who've really been, in my mind, pioneers and heroes. But we still lag in terms of local interest in surgery. This is a recent publication, just looking at what the Ugandan medical students are most interested in pursuing. And you can see there's one bar, it's infectious disease compared to everything else. So we still have a long way to go to make the surgery and perioperative professions more attractive. Personally, as a mostly US-based clinical trainee working with Dr. Kisa and her colleagues, I always feel like I learn much more than I ever have to teach, truthfully, and working in a resource-limited context in terms of the physical resources. What you see, the picture on the left of the screen, is a typical OR in the emergency room in Kampala that I operated in when I lived there, but also just emblematic of that there's just less to work with compared to the environment that we train in here. And there are just so many, I think, lessons that we need to bring back to our environment here that we traditionally have not, to make our care here better as well. To highlight a few things, we have worked with a lot of Ugandan colleagues to design and deliver this advanced trauma care course, which started when I was living in Uganda. It's exclusively taught by local faculty, mostly has targeted interns and residents. It's very cheap. The website is here. Over the last year, our colleagues have put a number of videos online that are all locally done that would encourage you to take a look at. And that has scaled up around the country. It's also been something that could scale up regionally. And we've looked more closely through qualitative research at the uptake and maintenance of these skills, which is challenging over time for any of the training programs like this and like the program that Dr. Kisa mentioned, creating capacity in the rural areas for pediatric surgery. Dr. Debas mentioned the Sustainable Development Goals. We've not done a great job traditionally of linking our work in surgery and anesthesia to issues like poverty eradication, gender-related issues, economic growth, and besides just UHC itself. And so these are areas where we have a lot of work to do. And because I think we haven't made that case so well in the surgical space, we haven't gotten a lot of funding. This is Walt Johnson's favorite slide. So I've taken it from him. He was at the WHO, for many of you that may have known him, but it just illustrates how much relative funding goes to HIV, TB, and malaria compared to surgery, despite the differences in disease burden. We talked about anesthesia and perioperative care. Those of you that are maybe working in Africa may be familiar with the ASOS study from 2017. The main takeaway was twice as high mortality in the African setting for even uncomplicated patients. And they're now doing ASOS too, but basically it highlights the need to rescue patients post-operatively who may not be doing well. And that's the topic of their second study. Putting on my anesthesia and perioperative care hat, access to pain is a major issue. Analgesia, it's something that we don't think about much as surgeons. Again, this extends to the space of you can't just do the operation, you have to take care of pain. And this is another major area that we're working on. When we ask our colleagues in Africa, as we've asked the pediatric surgeons, how can we help? And I think Dr. Kisa got to this, what should we do as partners? It's really, least rated here is direct care delivery. The highest rated here is local training, which is what we've tried to do, is to support the program that I know best, which is the training program in Uganda. And Dr. Kikembo, who's highlighted here on the left, was really, with Dr. Kisa and others, started a local database back in 2012, just handwriting it, and has maintained it over the years. And it's allowed us together to look at things like, well, how much of the disease burden are we treating? How much is unmet? Make some calculations on what we could be able to achieve, who could meet that need. Some of the students over the years who have helped with that are also pictured here. But it was a tremendous dedication of the local team to commit themselves, despite being clinically overreached, to actually looking at data. And that has allowed us to ask things like, what should we be collecting? How can we risk adjust this data? How much should we be sampling it? And that's informed bigger data collection strategies. To shift emphasis just a little bit to pediatric surgery and children's surgery, even a little bit more. 1.7 billion kids around the world lack access to surgery. It's a huge number. And if you look at specific children's surgical conditions, abdominal emergencies, congenital anomalies, injuries, cancer, major disparities between high and low income countries. I am a co-founder and the president-elect of this group called the Global Initiative for Children's Surgery, which I'm proud to be a part of. It's really tried to hit some of the gaps between global surgery and child health. We've tried to join some of the efforts in children's surgery, inspired largely by efforts like what Dr. Kisa was saying, where there's so many different stakeholders, but they're not talking to each other. And so that we've tried to kind of do that through GICS and really have it be led by LMIC. This is a picture from our last meeting in January of last year. I think it was the last meeting that many of us may have a picture like this, where we're standing shoulder to shoulder and being able to network. One of the outcomes and the outputs of that group has been what's called the ORCS document. We could work on maybe a better title, but for now it's the optimal resources for children's surgery, but it's really a blueprint for what might be needed at different levels of the healthcare system to deliver care. And many groups have used that to really look at in the individual level to a patient moving through the healthcare system, where the gaps are so they can meet the gaps. Some of the current challenges that we've identified through this group and others are PPE, healthcare worker protection, vaccine access, which right now in Uganda is about 2 to 3% in the population. And it's a major issue. The disruption to education, the need for guidelines for stopping and starting surgery. This issue of collateral damage due to the COVID pandemic is one that has been really hard to address. A lot of the systems have been focusing on the direct response to COVID. And as people in the surgery and perioperative space, we know there's been substantial collateral damage. And then I mentioned vaccine availability. So I think that the big picture for surgery, or global surgery, if you will, is, it's not just, the fly-in medical mission. And it's much more about long-term relationships and partnerships. And the field is moving, thanks to the work of people like Dr. Debas and many champions around the world, to a legitimate field of inquiry and work that we're all kind of working towards. And we've really tried to reframe the traditional narrative of surgery and anesthesia care as, focusing on, the challenges on the right side of the screen here, where, there's just not, we don't have enough, and there's really not much we could do to really, as you could hear from Dr. Kisa, and, an asset-based, thinking where we have, lots of lessons from the patients and communities that we treat. We have incredibly compassionate, dedicated teams. And then we have innovations that are happening on the ground that are applicable really anywhere that we haven't really acknowledged as such. So we still in the global surgery community have a lot of work to do to simplify our message. It's about the actors. We've had a lot of actors, no central actor. We haven't coalesced always around ideas or politics and issues. But these are all opportunities for us. So just to kind of wrap up, for those of you that are getting to know our center or maybe this area of work, think of surgical care as it's a priority in terms of a population health intervention. And I think what we've acknowledged is it's really about equity, regardless of geography, that drives most of us. That anesthesia and perioperative care are really critical. We can't do anything as surgeons without anesthesiologists and without nurses, and that we have to listen to local champions, frankly, whether it's in our local communities or internationally, to create any sustainable intervention. It has to be a team approach, as I feel like Dr. Kisa kind of stressed. I also just wanted to say another word about Dr. Mutumba, who Phyllis referenced in her talk. I met him in my early trips to Uganda about 20 years ago. He pioneered the field of pediatric surgery with Doreen Birabomale. And I can't think of a kinder, more open, welcoming man. We operated together. I can only think of how proud he would be of how much progress there's been. He had really big hands. And I always wondered, and with other ped surgeons that have big hands, I wonder how does it work? Because you're operating on such small babies. But also I just wanted to honor him and it's such a big loss for the Ugandan surgical community just a few weeks ago from COVID. So thank you, Dr. Mutumba, and best to his family and the surgical community in Kampala. Thanks very much.
Thank you, Dr. Kisa and Dr. Ozgediz. This has been an illuminating presentation. And what I get from listening to both of you is the importance of long-term partnership. Partnership that is win-win, that's of equal partners, that where the agenda is based on the priorities of the LMIC partner, but where both groups benefit. And I'm especially impressed by how graphically Dr. Kisa was able to illustrate that with her examples, with incredible achievement in separating twins and so on in low resource settings. That is really amazing. And Doruk, I want to congratulate you on founding CHESA. This is really a great achievement that you'll be proud of. Before I turn the question and answer period to Chelsie, let me ask you, Doruk, how you plan to stimulate collaboration and nurture the new center you have developed within UCSF and elsewhere. Thank you.
Thanks, Dr. Debas, for those comments. And I think really we have, distinct, I think, buckets of activity that are shared with our partners, which were highlighted in Dr. Kisa's talk, which is strengthening capacity and workforce. And I think, and research. I think those are areas where we all, have skin in the game, regardless of where we work or who we teach, whether it's here or international. So I think that's an area where there's a tremendous amount of synergy. So I think within our center, we have, a great opportunity to just harness the expertise that we have through our partnerships, and do things like formalize training pathways and make the training much more accessible to places and people that it hasn't been, and locally to also diversify our training. So I think it's really kind of around organizing around areas that we have synergy, and also taking advantage of specific clinical areas where we need to collaborate. Surgery and anesthesia is always a must. I think there are specific disease categories like pediatrics, trauma, oncology, where we also could take a more disease-based approach. But those are just a few thoughts.
Thank you. Chelsie, take it on.
Thank you so much, Dr. Debas, and thank you, Dr. Ozgediz and Dr. Kisa, for such wonderful talks. We have a couple questions coming in here. One saying, Dr. Ozgediz, you mentioned the need to integrate both local and community work and international work in surgical equity. What do you envision that integration looking like?
So yeah, thanks. I think we've done a disservice by siloing the spaces where we work. So, if we work locally, and by local, I mean local to where I'm sitting right now, which is in the Bay Area, we've not seen it the same way as when we're working internationally. I think it comes back to the basic concepts that are around access to care and social determinants of health, and some of the systemic factors that lead to surgical diseases or surround surgical diseases. And I think we just have to unify the approach. And I think we need to share the lessons in each space with the other. because the spaces have been separated, we haven't been able to take advantage of the relative truths. We haven't been able to share the innovations that happen by heroes and champions in low resource settings that might be applicable here. We haven't been able to share some of the successes that we've had here with vulnerable populations internationally. So I think, concretely, it's just by bringing the two together. I mean, in some ways, we have to do just a landscaping of, increasing the visibility of programs that work and making them more visible to folks that are working in either space. So we're hoping the center can be a hub for doing that. And not just our center really, but just our extended network of folks that are working in global surgery and health equity.
Thank you for that, Dr. Ozgediz. And our next question is commenting, really informative grand rounds, thank you. Saying, I have a big picture question because I do not have a lot of background knowledge about global surgery. When I think about surgical issues abroad, such as limited resources, which is associated with the aforementioned startling statistics and how long they've been around, what are the barriers keeping us from moving the needle? As an example, for lack of staffing, what's preventing locations from being appropriately staffed?
If I may take that one, Doruk can add something if I leave something out. I mean, about something like this, it all comes back to countries and their priorities. In global health, or even WHO, so to speak, everyone has prioritized infectious disease. So when we come to talking about people with problems, surgery is the unwanted stepchild, and pediatric surgery and anesthesia is really the child that you've killed. They're really not wanted by anyone. So by the time they come to the table of allocation of resources, it's really, they really don't have anything. I'll give you an example. At my hospital, I mean, they will stock all sorts of things like ET tubes for adults, but you'll never see an ET tube that is going to suit a baby that is 5 kilograms. It's not there. So unless you have some collaborator bring you something, but it tells you the country is full of children, but there'll be never anything that is provided for the child. And it just tells you something about how the government or the ministry prioritizes things. And a lot of this also comes from the priorities that an institution like WHO emphasizes. Because some of these things have shifted. Before, I mean, people were dying of diarrhea, malnutrition, and malaria, but these things have shifted. Right now, those things have reduced, and surgical problems are killing more people than infectious diseases. But, medical things have easy solutions. I mean, the initial cost to, a set of pills for 3 days for malaria is way cheaper than, what you think about you might need for a surgical procedure. But in the grand scheme of things, it's much cheaper when you bring it all together. But this is one of the things. Then when it comes to things like staffing, in a place like Uganda, this salary is really, to your ears, it is ridiculous. And you'll wonder how some of us wake up and go to work. And so to keep someone in such a job, it almost seems like a thankless job. You can barely support yourself. Many people do stray away from such a, so how many times you get more people, they will go away to something else. People have got to make a living, and sometimes you don't blame them. And it's not even brain drain. People sometimes find other things to do. They're businessmen, they're selling cars, they have lots of shops. And so very people come into medicine because of the poor pay and long hours and, how it can be crazy. But also, I mean, when you're in there, you don't have the tools you need. And so you find something else to do. Unless Doruk has something else to say.
I think you've covered it.
Sorry, that was like a lecture.
Great.
And I think that our next question ties in perfectly to that. Someone is introducing and saying, I'm a second-year med student in Uganda. I'm very amazed at what we've done in Uganda and appreciate the work that doctors like Dr. Kisa are doing. My question is, how do you approach educating us? Because most of what has been said is news to me. And how are we to attract more med students and others in Uganda towards surgery? Because most of my friends do not really want to go into surgery, but I do.
Well, I think surgeons, as a general rule, maybe in America they're different, but in Uganda, as a general rule, we have poor advocates for ourselves. But that is one of the things we need to learn, how to be able to advertise ourselves. You need to be able to showcase what you do, probably do more grand rounds, showing some of the cases that we do, showing how some of these challenges can be met and the like. There's so many people who do very little and they're always in the media, but none of us is like that. And even with some of the twins we've separated, so many people do not know. Actually, even some surgeons don't know that we've separated another 2 sets of conjoined twins in the country in the last 3 months. But it's because we don't want, people to make it difficult to do our jobs. When it gets out there, the media just makes it difficult to do your job. And that's why sometimes we keep these things quiet. But I think you raise a valid point, and surgeons, we're not doing a good job in advertising for people to come to join us. Pediatrics does a very good job. Obs-Gyn does a good job. Anesthesia, and they get lots of trainees coming there. And I think this is a challenge that the associations of surgeons in Uganda will have to do to be able to advertise what we do and what type of satisfaction you might get personally as a surgeon.
Thank you. And I think as we're thinking about, both limited people power and limited resources, our next question asks Dr. Ozgediz, what do you think partnerships between institutions like yours and CHESA should focus on as a primary objective? Service provision or training?
So thanks. And I see that's from Professor Bekele. So I have to, first of all, thank him for joining. It's great to have you join us. And for those of you who don't know, Professor Bekele is based in Rwanda, the Dean of the School of Medicine, and has done an incredible amount leading educational efforts in both Ethiopia and in the CHESA region. So Professor Bekele, I would say I would take your lead is number one, but I guess my observation has been, and one of the great things about CHESA is that it's allowed training to happen while providing service. So, and I think that's been a tremendous innovation. And for those of you that may not be familiar with the organization, it is the Regional Association in East Central and Southern Africa, and it allows fellows to train, it accredits sites for training and allows them to train without leaving their training site unless they have specific gaps in certain areas. So I think that what we found is that there are ways to do both, Professor Bekele, and I think that's part of like what we need to kind of innovate, is that we can both provide service and train at the same time. And I think that's what we found with some of the outreaches that we've done with Dr. Kisa and her team, is that local trainees have really led those outreaches, and they've had both local and international supervision. So they've been able to actually get extra reps doing cases in a supervised setting while providing service to a community that hasn't had access. And if it's consistent and organized well, it can work. And I'm curious what what Dr. Kisa thinks, but I think we would hope as a center to be able to support both those activities, but of course take a local lead. I would say the anesthesia part of it is also equally important. Anesthesia trainees that go out on these outreaches have a chance also to work with the local anesthesia teams. Often they're anesthesia officers, and there's a tremendous amount of on-the-job learning and sustained relationships that allow the service delivery to continue after that type of activity. So if they're organized well, they can really work. But I wonder what Dr. Kisa thinks about the training versus service delivery question.
Well, I think that a blend is what's required. I think you cannot separate the two. Surgical training happens in doing. And if you separate the two, you're not doing what you're supposed to do. When we go to these camps, we're teaching surgeons and ourselves more than just doing the operation. It's dealing with the environment, dealing with challenges and being able to think through them and meet them. Those are some of the things, but also having to deal with more cases, maybe different presentations to what you normally would see in your own center, working with different people. These are opportunities that you can't put aside. But like in the slide I showed before about in Uganda having 6 surgeons, I'll tell you something. We had the first fellowship trained pediatric surgeon in Uganda in 2010. It's now 11 years later and we have only 7. That should tell you something. We're not going to get there. And when you only say you're going to teach, teaching is based on people having the prior interest to come to you to teach them. And if they don't have it, you're going to have to continue offering clinical services as well. So collaboration must also in other ways find a way to offer the services. So whether, I remember in the CHESA region in the past, they would ask surgeons from the region to go to some of the other countries, like go to Malawi, go to Lesotho for a surgical camp, and it's sourced within the CHESA region to do such a thing. And in the same way that we also do that, surgeons from the capital of Uganda will go to another regional hospital to do that. It's because teaching alone is not going to get you there, because to be able to teach and for someone to stay there to do the job you've taught them, they have to be interested. The passion has to be there. As soon as you leave, if they don't want it, that is the end of that activity. But if they have a passion for it and they've actually been mentored through it and they're the right person, then they'll continue. But it's not easy because, I mean, you saw that graph that Doruk chose. Infectious diseases is the first choice. The person that chooses surgery is really the outlier. And even when you go into pediatric surgery or even pediatric anesthesia, those are even a smaller group. They're very few. And along the way, they get other distractions, quicker money. And I mean, life happens and you've got to pay bills, family happens, and priorities are going to change. And you cannot begrudge people some of these choices. If they're not going to be there for the long haul, then they're the wrong people. So on my end, I'd rather wait for the right person, in the meantime suffer. So I believe in the training and both the clinical care being offered, because right now they are necessary. And actually brings me to another question. I'm sorry, Chelsie, I'm going to go to that question that Dennis Zeng has written there about the parachuting surgeon or surgical camps. Of course, the surgeon that just comes in, does what they do. This is what people did before. Someone comes in once in their life and they never go back to a center, do all sorts of surgeries. The most qualified person in that center is probably a nurse or maybe a non, or rather a physician surgeon, but who's not residence trained or something like that. And they do all sorts of surgeons, lots of complications, and then they zoom off at the end of 1 week, leaving you with all the patients, all sorts of complications. But someone who's never had the specific type of surgical training cannot fathom the types of complications that might happen. They can't troubleshoot them. They cannot act. Lots of bad things happen when this type of thing happens. But one of the things I mentioned that in these types of fellowship, the need has to change, and you have to learn from our mistakes. So if we come from a place where surgical camps is offering the best thing for us, then at some point there's something we get more, like after we've offered camps, you've gotten some more people interested, we've been able to train people, so you continue supporting them in those different needs. And it should change from the parachuting person, because now you have, for example, someone like myself as a key surgeon in that area to hold the bag. So when you leave, I still have care for that patient. I have been trained and I can troubleshoot through the complications. If it's beyond me, we are colleagues and I can always ask you these questions. But it's different when you ask someone who's only gone through medical school to look after a patient who's had a pull for, let's say, a cloaca. If things go wrong, they really do go wrong, and they don't know what to do for such a patient. So, but also I think at this point in time, is people to recognize that in such things, like, both groups have something to bring to the table. I've got something to bring, and someone from, say, UCSF has something to bring. And if you're in an LMIC setting, or you're the host surgeon of some setting where you really need help, you need to be able to speak up. You know your priorities best. So the person who's parachuting in, you're like, no, maybe you need to speak up and say, this is not safe if you're leaving in 5 days. It's not going to help us if you do all this stuff and you're going to go away. The last time you came, or someone like you came, they left me with all this type of work and I was not able to manage, and this is what happened to the patient. And sometimes you don't communicate well, but it's one of the things people need to learn to do. You have to communicate what your needs are, and so you will help your own patients and or your center prevent people of this type coming in and not communicating what they're doing, do all sorts of things that you don't understand, and then they go off and leave you with the burden of dealing with that, the complications, and the families when things go wrong. I don't know if that answers that question. Or questions.
Thank you so much, Dr. Kisa and Dr. Ozgediz, for such a rich discussion. Unfortunately, we weren't able to get to a few questions, a couple that we can consider for future grand rounds. Asking here, how can public health and surgery be able to meet? We rarely have any students at Makerere University School of Public Health doing a dissertation in surgery. And another question asking, how do we best incorporate public policy advocacy into global surgery work? How much interest has the Ugandan government and Ministry of Health had in the development of pediatric surgery in the country? So I think those would be great things to consider for our next Grand Rounds. And I'm going to pass it back over to Dr. Debas.
Well, thank you, Chelsie. And I just want to thank Dr. Kisa and Dr. Ozgediz for a wonderful Grand Rounds. Your presentations have really been illuminating. Thank you. And I would also like to thank Chelsie Anderson. She is a great moderator, as you see. Now, I think I've enjoyed this first Grand Rounds. There will be many more that CHESA is going to put on, and we look forward to your attending future CHESA Grand Rounds. So thank you very, very much.